a lady has to bear the children. If she doesn't bear a child, that means she is labeled as infertile. But most of the fertile men will have at least 50 million, 60 million count.
Yes.
At least if we do 5 tests, at least 3-4 times he should have 15 million. Then only the lady can conceive. Obesity causes infertility. Smoking causes infertility.
Yes.
They may not cause direct cause, but indirectly they contribute to all this infertility.
Hello, sir.
Good evening. Can you hear me?
I can hear you.
Am I audible? Yeah.
How have you been since we last spoke? Very busy?
Not so much. Usual workflow.
Right. Well, I cannot thank you enough for agreeing to come.
As usual. Yeah.
Right.
No, it's my pleasure to be always with you. Whenever you want, you can count upon me.
Well, thank you.
If you want, I can come weekly once also.
Yes, thank you so much. There aren't too many people who is a sexologist like you and who deals with men's health like you. And
yeah,
very important that male issue is also raised so that men and as well as women understand the complexity of fertility issues and the surroundings.
Very true.
Right. So, well, for our viewers' benefit, could you kindly introduce yourself?
I am Dr. Sharath Kumar. Mainly, I'm an infertility specialist with a special interest in male infertility. I am PhD in male infertility and MS in fertility, as well as I'm a sexologist. I'm a fellow of the European College of Sexology. So I practice sexology, infertility, in particular male infertility. So it is my main subject is male infertility as well as sexology.
Right.
So I'll be very happy to talk on the topic which I like, because the male infertility is the one topic which has been constantly ignored by most of the people. Whenever a couple doesn't conceive, it is the female partner who is blamed. The male partner is not examined at all many times. Of course, from past 1 decade, there is a change. People are realizing that the male factor also plays an important role. In fact, as far as the WHO statistics is concerned, in an infertility couple, if you take 100 couple, the 40% contributory factor comes from the male only, and the other 40% from the female, and the 10% from the combined factors, both male and female equally involved, and another 10% unexplained infertility, where the cause is not yet explained. This shows an enormous amount that in any couple, if there is no conception, it means the possibility is 50-50. The possibility may be 50% male or 50% female. And another wonderful thing about the male infertility is it is very easy to diagnose a male infertility. Just one semen examination, you can label whether that person is fertile or not. Whereas to diagnose female infertility, she has to undergo so many tests, like ultrasound scanning of the ovaries, ovulation studies, endometrial studies, tube test, hormone test, and so on and so on. Ultimately, even she may have to undergo even a laparoscopy to find out whether she is fertile or not. Male is very simple. Just examine external examination, see whether he has got a penis, see whether there are 2 testes, fine. And just get one semen test. And just only one question to be asked for him. Can you do intercourse? If he says yes, it's finished. Whereas for the female, it is not like that. Do you get the cycles regularly? Are you ovulating? Are you having sex regularly? During the fertile periods, are you having intercourse? So many other additional questions have to be answered by the female. And one more thing about the society, particularly in Asian countries, especially in India, is that a lady has to bear the children. If she doesn't bear a child, that means she is labeled as infertile, irrespective whether the male has got azoospermia or whether he has got totally coital failure, whether he has got micropenis, undescended testes, the label comes on the female.
Yes.
So coming to the male, yeah, you have any question, Jami?
Yeah, you said that a male has got, so you ask a few basic questions like if they're able to have intercourse or not. And after that, you only have one test done for the male, right?
Yeah.
So for this one test, what are the specific things that are looked at?
Yeah, as far as the WHO parameters are concerned, the basic test is the sperm motility, sperm count, and sperm morphology. Okay. And these are the three basic things. Of course, there are several other things also, fructose study, then a DNA fragmentation study, head study of the sperm, tile study, and penetrative capacity, the study of the sperm. All those things, they come second. That is, the first basic things is about the morphology of the sperm. Whether the head is okay, the neck is okay, the body is okay, tail is okay. How many sperms per 100 normal in morphology? Do they have double head? Do they have no head tail at all? And so on. That is the morphology and the count. How many sperms are there per million? Is it at least 14 to 15 million per ml? And is it constant? If you take 3 to 5 samples, all the 3 to 5 samples, whether the person was able to get at least 15 million in each sample.
Oh, that's
and
interesting.
The motility.
So the count has to be constant, right?
Yeah. No, not below that. Not below that. Okay. Because what happens is, sperms, semen analysis, if they do several times, it will be sometimes 50 million, 40 million, 80 million, 100 million, 120 million also. But it should not come down below 14. I am telling the lower limit. Lower limit is 14 million. The ideal will be at least 20 million. But the WHO parameter says 40 million, at least 15 million. But most of the fertile men will have at least 50 million, 60 million count. In fact, the sperm count, when we studied the medical, this one in 1980s, it was said that 60 million is the normal. Okay. Then they brought down to 40 million. Then they were very kind towards the male. They said, okay, you have at least 20 million. Now the WHO has again come to the rescue of the male, saying that at least you produce 15 million. And if it doesn't produce 15 million continuously, that is, at least if we do 5 tests, at least 3-4 times you should have 15 million, then only the lady can conceive. Otherwise, it will be labeled as oligospermia, asthenospermia, oligoasthenospermia, oligoasthenoteratozoospermia, so on, depending upon the motility, the count, the morphology.
So the 40-50 million thing that we are speaking about is per one ejaculate, right?
Yeah, one per ml. Per ml. And per ml, per ejaculate, it should be at least 1.5 to 2.5 ml. Okay. That is minimum at least 2 ml. Okay. And if it's only a 0.5 ml, it cannot reach the cervix at all. It will be all gone into your vagina only. How can it reach the ovaries? So per ejaculate, at least it should produce 2.5 ml. Okay, bare minimum 1.5 ml. Otherwise, it will be something like asamenemia, no semen at all. For example, if one produces 1 drop of semen, and if the count is 200 million, if the motility is 90%, what is the use? Because that 1 drop cannot reach even the cervix, let alone going to the vagina. So the volume is also very, very important. Otherwise, it will be labeled as hypovolemia. Hypovolemia, and then aspermia, azoospermia. All these are some of the main causes for male infertility. So volume also equally is, and this volume should be at least, if you ejaculate 5 times with 3 days abstinence, you should be able to produce at least 3 to 4 times, at least 2.5 ml. Once in a way, of course, anybody can have less semen, especially when they masturbate in when an environment where he is not convenient. For example, in an IVF center, he may not get the full mood and he may come out with only 1 ml. That is once in a way. But in his bedroom, he should be able to produce 3 ml at that time. So the volume should be constant and it should not be less than 1.5 ml at any given time.
So we've got...
What I'm talking is the
minimum. So we've got... For one semen test, we've got motility, sperm count, morphology, DNA fragmentation, and what else?
Fructose.
Okay.
Fructose studies.
What is that?
That is the energy which is released from the prostate, which joins the semen. And that is required for the sperm to maintain the energy till it reaches the egg, that is the ovum. So that fructose should be positive. It should be there.
Right. Apart from the specific reasons like not to smoke, not to drink, etc., and also lifestyle changes, what are the most, commonly seen fertility issues in male, according to your experience?
The main contributory factors for the male infertility are cryptorchism, undescended testes, and testicular atrophy, and the small testes. That is, the testicular volume will be less, and one test will be absent. He might have had some injury during the childhood, or mumps infection, where the testis has been destroyed due to infection. So testes have to be examined first. And we can classify the male infertility into 3 groups: pre-testicular, testicular, and post-testicular. So pre-testicular reasons are the reasons of low sperm count due to reasons before the testis. That is, right from the head, the hypothalamus, thalamus, even the thyroid, even the adrenals, and all those hormones which do affect on the spermatogenesis. If they are absent or if they are not up to the mark, then there could be a sort of low count option. So I was talking about the causes for male infertility: pre-testicular cause, testicular cause, and post-testicular cause. Pre-testicular causes are mainly hormonal in nature, where there may be absence of FSH and LH liberated from the pituitary, or maybe absence of the testosterone, or maybe some congenital abnormalities, and there may be some deformities which give rise to Klinefelter syndrome, chromosomal problems, or any genetic abnormalities, that is like Kalman syndrome. So whatever the brain activity which controls the spermatogenesis, that may be absent or defective. That is pre-testicular causes, mainly hormone. Testicular causes are the testicular atrophy, undescended testes, or chronic epididymoarthritis, where there will be infection of the testicular tissue, damaging the seminiferous tubules and spermatogenetic things. So that could be the testicular cause. And post-testicular causes are very, very important because they are treatable. And post-testicular cause mainly is obstruction in the vas deferens. Now we can have the sessions like the treatment aspect. We can start with the 3 treatment aspects. For one is for 3 pre-testicular causes, second testicular causes, and post-testicular causes. We can divide, and for each we can have talk 30 minutes, and one lifestyle modification for in general. That is for the male infertility. So 4 sessions we can have. One is common for all the people. For example, obesity causes infertility, smoking causes infertility. They may not cause direct cause, but indirectly they contribute to all this infertility, causative factors. And chronic alcoholic, it can cause infertility. So what we can divide, so 3 sessions we can have treatment as well.
That's wonderful. Thank you, doctor.
And one for diagnosis. Thank you so much. Okay.
Well, Dr. Sharath, it's always a pleasure to talk to you and tap into your immense wealth of knowledge. Thank you for agreeing to share your knowledge with us.
No, knowledge is one. It is like a light. You should spread the knowledge. Then only get more knowledge. By well, talking to you, I get more additional knowledge because I prepare for that. And when I go through the literature, again, I'll be enlightened. And to speak, we have to be prepared. And to prepare, we have to learn. So it's a learning object when we talk to others and when we share our knowledge. So by spreading the knowledge, we get more knowledge rather than other getting the knowledge.
True, true, very true. Thank you so much, Dr. Sharath. God bless you.
Yeah, yeah. Thank you. Thank you. Good night to you.
Good night.